so now I'll share my screen PowerPoints. Anybody have any questions or comments? Okay. All right, so let me record. And we'll get started. Okay, so obsessive compulsive disorder. The presence of obsessions, compulsions, or both that are severe enough to cause distress or impairment. That, of course, again, makes it an disorder. And it affects all aspects of their life, work, school, and personal relationships. OCD is a common, chronic, and long-lasting disorder where a person has uncomfortable, reoccurring thoughts. Those are the obsessions and or behaviors, and the behaviors are the compulsions that they feel the urge to repeat over and over. So they have the thought, and then they have the compulsion. It's very disabling anxiety disorder. They have obsessive thoughts, compulsive repetitive behaviors, and it really dominates their whole life. The DSM-5 criteria states that for it to be, I mean, some people are a little germ phobic, and hopefully all of us as nursing students and nurses are a tad germ phobic, because that's important. But to have the obsessive compulsive disorder, you must lose at least an hour or more a day doing this obsession compulsive act. And it differs from double checking. I know I've thought, oh my gosh, did I turn off my curling iron, or did I lock the door, and go back and check? But it didn't take more than an hour of my day going back and checking and checking and checking. And as you could see in this movie, he had the number thing too. He was like 5 times. He had to do everything 5 times, and several bars of soap, washing his hands with really hot water. And it really took a lot of his day doing these compulsive acts. You always want to rule out that it's related to any substance or a medical condition, and it can't be explained by any other mental health disorder. So also there's different levels. If they have insight, there's a much better prognosis. If they don't see, kind of like our manic patients, that they're doing anything wrong, that there's anything wrong with what they're doing, they have a poorer prognosis. But they have insight into, yeah, I know this is not normal to do this, but I can't help myself. They have a better prognosis. So the obsession is the recurrent thoughts, urges, or mental images that cause anxiety. Okay. The obsessions are very intrusive and recurrent and stressful. The individual typically recognizes them as an irrational behavior, but the thoughts continue. They cannot block these thoughts out. They tend to be very repetitive, and they just can't ignore them. Common obsessions: fear of germs or contamination, unwanted or forbidden taboo thoughts that they have involving sex, religion, and harm, or aggressive thoughts towards others or themselves, and having things in symmetrical order or in perfect order is another common obsession. So that's the obsession. The compulsion is the repetitive ritualistic behavior or mental act that the individual feels driven to perform. It's intended so they feel anxious about the obsession, and the compulsion is the act is intended to reduce the anxiety that's associated with that obsessive thought. So that's why they do these compulsive acts. The individual recognizes the behavior is excessive also, typically, and unreasonable, but because that act gives them a temporary relief of that anxiety that's caused by the obsession, they're compelled to continue to do that. So they worry about germs, so they go wash their hands and wash their hands. They worry about somebody breaking in their house, so they lock the door and lock the door. However, this does not apply to young children. Young children are not able to have that insight into their disorder. So compulsions are repetitive behaviors that a person with OCD feels the urge to do in response to that obsessive thought. So obsessive compulsions are excessive cleaning, excessive hand washing, ordering and arranging things in a particular order, repeatedly checking on things, such as repeatedly checking that door. Is that door locked? Is that door locked? And again, checking is normal. Did I lock that door? But doing it for more than an hour is not. That's when it becomes a disorder. Or if the oven's turned off is another example. Or counting. Like he was doing the lock, he counted. He had to do it 5 times, compulsive counting. And so just, keep in mind, if you start worrying about, oh no, do I have OCD? And we, sometimes kid each other about that, although we should not, but because there's people that actually have this disorder, which is disabling because it takes up so much of their time and interferes in their ability to work and have interpersonal relationships. So, but again, everybody doubles checks, but a person with OCD generally can't control their thoughts or behaviors, even when those thoughts and behaviors are recognized as excessive. Again, they spend at least 1 hour of the day on these thoughts or behaviors, and they don't get pleasure when performing the behaviors or the rituals, but again, they feel a small, brief relief from the anxiety the thoughts cause. So they're worrying about germs, and so they wash their hands to decrease that anxiety, but it's only short-lived. And again, they experience significant problems in their daily life because of these thoughts and behaviors. Also, just to add, some of these individuals do have tic disorder, where their motor tics, which are sudden, brief, repetitive movements such as eye blinking or eye movements or facial grimacing, shoulder shrugging, head and shoulder jerking. Some vocal tics that can be common vocal tics that they can have are repetitive clearing their throat, sniffing, or grunting sounds. I'll spare you the grunting sounds. So the cause is there tends to be, yes, a genetic predisposition for this. They have found in brain imaging studies that there is a difference in the frontal cortex and the subcortical structures of the brain in patients with OCD. They also have found that there's been a history of childhood trauma, and most individuals this affects are adults, adolescents, and children, and most are diagnosed by about 19. Typically with an earlier age of onset in boys than in girls. So they see this earlier in boys than in girls, but rarely happens after 35. Or it doesn't happen after 35. Twin and family studies have shown that people with first-degree relatives like parents, siblings, or their child with OCD are at higher risk for developing OCD. So there is a definite genetic predisposition for this. So another cause they have found is children that develop a streptococcal infection can develop OCD or OCD symptoms after this infection. And this is called pediatric autoimmune neuropsychiatric disorder. So they have found, or PANDAS, they have found this to happen. They've also related it to a serotonin dysregulation, a problem with serotonin, our neurotransmitter. The psychoanalytic theory on why this develops is that folks with OCD have a weak, underdeveloped ego due to unsatisfactory parent-child relationships that involve conditional love or provisional gratification. The aggressive impulses that are caused from this are channeled into thoughts and behaviors that prevent those feelings of aggression from surfacing and producing intense anxiety, fright, and guilt. So that's the analytical theory on that. The learned theory is that it is a conditioned response to a traumatic event. So they can have passive avoidance where the traumatic event produces anxiety and discomfort. So the individual avoids the situation that causes that, or active avoidance where when it can't be avoided, the individual learns to engage in behavior that provides relief from the anxiety associated with a traumatic situation. Clinical manifestation, the most frequently reported obsessions are repeated thoughts about contamination, germs, repeated doubts with fear, that they've hurt someone, that they've left the door unlocked, needing to have things in a certain order. So those are the obsessions, and the most frequently reported compulsions we see are hand washing, ordering, checking, locking doors, a mental activity that they have to repetitively go through, like praying or counting over and over and over, or requesting or demanding assurance, needing that feedback, constant feedback, or ritualistic behaviors, any ritualistic behavior. So let's look at a question. A newly admitted client diagnosed with obsessive compulsive disorder spends 1 hour packing and unpacking, folding and refolding personal belongings. What is the most likely reason for this behavior? Anybody can just shout it out. A, very good. It relieves the anxiety. So the recurrent thought that an individual is unable to put out of their mind and the actions that the individual is unable to refrain from performing the compulsion. So the thoughts are the obsessions, the act is the compulsion, directs that client away from the underlying anxiety and focuses the client on the repetitive activity. So that, keeps them from thinking about their anxiety, such as packing and unpacking, folding and refolding belongings. So it's to decrease their anxiety. Okay, treatment modalities. OCD typically is treated with medication and psychotherapy, a combination of the two. Although most patients respond to treatment, some continue to experience their symptoms. Individual psychotherapy helps by allowing them to discuss their anxiety issues, and that, of course, decreases their anxiety. And it helps them identify their strengths, their personal strengths, and help them develop more adaptive coping mechanisms. Cognitive therapy, try to change the thinking process, is related to how the person responds to the stress. Appraisal of the danger and unable to cope, reduce anxiety response by altering cognitive distortions. So we try to think, with cognitive therapy, they're trying to change the way they think about that compulsive thought. Obsessive thought. So research has shown that cognitive behavior therapy with exposure and response prevention. In other words, this is spending time in the very situation that triggers the compulsion, like touching dirty objects, okay? So they have them touch the dirty object, but then prevent them from doing the usual compulsive act like hand washing. That they found is helpful in reducing those compulsive behaviors. So you just expose them to that obsessive thought of germ situation, and then you don't let them wash their hands. So this has shown to be effective to help with OCD. Systematic desensitization, you gradually expose that person to the anxiety stimulus. So just, put them in a situation where they're going to be touching dirty objects, and they have to use relaxation techniques instead of doing that compulsive act. And then this kind of similar is explosive therapy, where they must imagine or participate in that situation that frightens them, that that brings anxiety, until their anxiety is less at the very beginning. So those are some different kind of treatment modalities that they can use. If we look at medication, the first line of defense with our medications is our SSRIs. Our SSRIs require a higher daily dose in the treatment of OCD than in depression. So they are on higher doses than we would have someone who is being treated for depression. And it can take 8 to 12 weeks to start working. So it takes a long time, pretty significant period of time for those to kick in and start helping. But some experience improvement more rapidly. Some side effects, of course, of our SSRIs are sleep disturbance, headache, restlessness. And I've listed fluoxetine, paroxetine, sertraline, and fluroxamine are our SSRIs. And then our tricyclic is clomepramine. And of course, it is also a good antidepressant, but because of the side effects, we try to use the SSRIs first. And that's the same with depression, right? We want to use those because of the less side effects involved. So our nursing diagnosis we would have for these folks is ineffective coping, of course, and ineffective role performance. It interferes with their role in life. So they have a problem holding on to jobs also. Goal is to decrease the participation in that ritualistic behavior by half within a week. Very measurable goal. Also to demonstrate more adaptive coping strategies. So we're trying to work with them to come up with more adaptive coping strategies that don't, occupy their life and hinder them from, going to their job and going to school and those kinds of things, for dealing with that anxiety and ritualistic behavior. Come up with more adaptive coping strategies. So definitely managing their anxiety is very important. So we want to help them come up with ways to decrease their anxiety and without having to resort to the ritualistic behavior, and develop more adaptive methods of coping with anxiety. So we're going to be working with them to determine what types of situations increase their anxiety and result in ritualistic behaviors. Now, in the beginning of treatment, you want to allow them plenty of time for their rituals. You don't want to be judgmental or verbalize disapproval of the behavior. You want to allow them to have plenty of time to do their ritualistic behavior when they first come, when they're first admitted. And of course, we're going to support them in exploring the reason for the meaning and the purpose of their behavior. We want to definitely provide structured activities, including, again, adequate time for the completion of their rituals. And then we're going to gradually begin to limit the time allotted for the ritualistic behavior as the client becomes more involved in other activities. We want to definitely, but I want you to start and remember that in the beginning, we want to allow them plenty of time for those rituals. Okay, so, but gradually, we want to begin to limit. Okay, but initially, no, we don't want to limit. We want to allow them plenty of time, because of course, being admitted into, a facility, a mental health ward, is going to be anxious enough for them. So, you don't want to do it initially, but gradually then you'll limit the time allotted for the ritualistic behavior as the client becomes more involved in other activities. So, you want to try to get them involved in other activities. And definitely we're always giving positive reinforcement for not doing those ritualistic behaviors. Education is very important. So we're going to educate the family and the patient on what OCD is, the symptoms of OCD, stress management, teach ways to interrupt that escalating anxiety, and teach relaxation techniques. Medication management, definitely we need to teach them about our antidepressants, our SSRIs, and the possible adverse effects of those. And also the length of time, which is going to take a while to see the expected improvement with the medication. Definitely connect them with support services, and stress management is definitely important to keep that anxiety in check. So teach ways, again, to decrease that anxiety, and relaxation techniques are good. Okay. Evaluation, our client reports reduction in the performance of that ritualistic compulsive behavior and demonstrates adequate coping skills to control anxiety. All right, so that is our obsessive compulsive disorder. Any questions about that? Okay, well, let's take a quick 10-minute break. Let's see. So the new calendar will be posted in Blackboard. I did talk to Ms. Bowie about that. Okay, so she is working on taking the old calendar out and putting the new calendar in. Okay, so come back about 10 after 10, and we're going to do eating disorders next. I'm going to pause the recording, so remind me to start it back up. Record button and share my screen with you guys. Miss Bowie wanted to make sure that you could see the calendar, and I think that's what Tracy meant, that the new calendar was up. And then if you can check and see if you can see the simulation for this afternoon, it is posted. If somebody wants to do that, or we can do that the next break. Okay. Any questions before we get started again? Okay, I'll share my screen. All right, eating disorders. Okay, so the hypothalamus is where the appetite regulation center is in the brain, and it influences or it regulates the body's ability to recognize when, we need to eat, when we're hungry, when you're not hungry, and when you are full or satisfied or sated. Eating behaviors are definitely influenced by society. We go out to eat. It's a social time for us, and our culture. Historically, society and culture have also influenced what is considered a desirable female body. So, like in the Roaring 20s, Twiggy, that look was in. Back in the 1800s, it was healthier to have weight to go through the times of famines. So they were the more desirable, the more voluptuous figure. But of course, today our culture is definitely advocates or look at the desirable female body as thin. So, of course, that influences some of our eating disorders. And our first one is anorexia nervosa. And it occurs predominantly in girls and women ages 12 to 30, in about 1% of the population. They have a major fear of obesity, just devastating fear of getting obese. And when they look at their body in the mirror, they have a distortion, a gross distortion. So even when they're skin and bones, they look in the mirror, they don't see that. They see themselves as still needing to lose weight. So weight loss is very extreme, and more than 15% of the expected weight. So they weigh less than they're in the less than 85 percentile as far as expected weight. And it's usually weight loss is accomplished by reducing food and often excessive exercise. They will also self-induce vomiting and can abuse laxative or diuretics, also can be involved. Other symptoms you're going to see with these girls are typically girls, but there are becoming, it's becoming more predominant in boys also. They're cold, hypothermia, they don't have any fat on their bones, so that they do tend to have hypothermia, bradycardia, hypotension. They do tend to be edematous, and they've got lanugo. And as you remember from OB, lanugo is that fine downy hair that babies have when they're born, and they develop that. And definitely have a variety of metabolic changes that occur.
Ms. Chandler, did you say hypertension or hypo?
Hypo.
Okay, thank you.
Hypo, yes. So they have a real preoccupation and obsession with food. They may even hoard food or conceal food. They talk about food a lot. They talk about recipes at great length and will prepare these elaborate meals for others, but then only allow themselves to eat just a small amount. And sometimes they just totally refuse to eat. Amenorrhea is typical with these girls. And sometimes it even is seen before significant weight loss. They tend to have problems with anxiety and depression are very common. Then the other disorder we have, eating disorder, or another eating disorder, is bulimia nervosa. And this is actually more prevalent than anorexia nervosa. And the estimate is up to 4% of our young women are affected by this. The onset of bulimia nervosa occurs in late adolescence or early adulthood, and it occurs primarily in societies that emphasize thinness, which is our society, our culture. So what bulimia is an episodic, uncontrolled compulsion act, right, to rapidly ingest large quantities of food over a short period of time, and that's called the binging. And then the episode of binging is followed by an inappropriate compensatory, I can't say that, compensating behavior to rid the body of the excess calories with purging or purging behaviors. So it's about binging and purging. The purging is self-induced vomiting or misuse of laxative, diuretics, or enemas, okay? So they do this by sticking their finger down their throat. So sometimes what we'll see with these girls is, scabs on their knuckles because of their tendency to, put their finger down their throat to get rid of the food that they just ate. They can also go through fasting periods, and or excessive exercise may also occur. Most patients, which you need to remember, with bulimia are within the normal weight range. Some may be just slightly underweight, and some might be slightly overweight. And depression, anxiety, and substance abuse. Well, depression and anxiety, just as anorexia, are common, and substance abuse can also occur or is common with these folks. And of course, excessive vomiting and laxative or diuretic abuse leads to problems with dehydration and electrolyte imbalances. So they will come in with major electrolyte imbalances and maybe coming in with dehydration. Okay, so everybody clear on the differences between anorexia and bulimia?
Yes.
Okay, great. Okay. The next eating disorder is binge eating disorder. So this is a variant of a compulsive overeating or overeating. And it's where the person has reoccurrent thoughts about eating large amounts of food in a short period of time. And episodes of thinking about it and then eating the large amount of food in a short period of time. After they do this, they feel, guilty about it. They feel ashamed of themselves, and it depresses them after the binging. And 50% of the individuals with binge eating disorder have depression also. The DSM-5 identifies binge eating disorder as an eating disorder that can lead to obesity. The individual, of course, binges on large amounts of food, as in bulimia, but the difference is they don't engage in the ridding the body of the excess calories. They don't do the purging. So they do the binging, but they don't do the purging. Possible triggers are definitely related to stressors, low self-esteem or boredom, and again, accompanies guilt and depression after the binging. They have a higher rate of improvement than those with bulimia nervosa. So when we look at body mass, what's considered obese is the index, the BMI of 30 or greater. 69% of adult Americans are overweight. So 69% of Americans are overweight. 35% of Americans are obese in our country. The biological influence, genetic, there is a hereditary predisposition for eating disorders. Anorexia nervosa is common among sisters and mothers of those with the disorder. So that tells us that there is a genetic predisposition for this. Biological influences, they found the neuroendocrine abnormalities exist in the hypothalamus, which is our appetite regulator, is not functioning properly in our folks with anorexia nervosa. It can also be neurochemical imbalances that are found with bulimia. It's more associated with the neurotransmitters serotonin and norepinephrine. And anorexia are more associated with, or actually something different. Okay, so bulimia is associated with the neurotransmitters serotonin and norepinephrine. They haven't really found that with anorexia, but what they have found that these folks have high levels of endogenous opioids in their system. In other words, they're natural inside the body opioids. Okay. So they found those in spinal fluid of anorexic patients. And so they speculate that, this occurs And this contributes because typically opioids decrease our appetite. So this contributes to their denial of hunger, that they deny that hunger. Some patients gained weight when given naloxone, okay, or Narcan. So that made them think, okay, there is a correlation of the opioids and that triggering them to deny their hunger response. There are questions whether the neurochemical changes are caused by the body being deprived of food, or is it caused, whether the neurochemical changes are caused or are an outcome of the body's reaction. So is it something that's found in these people that caused them to become anorexic, or is it something that occurs because of their anorexia? They're not sure about that, but they have found that. Psychodynamic influences suggest that they result, reading disorders result from very early and profound disturbances, again, in the mother-infant interactions. So again, children can get damaged, so we need to be good mothers and fathers to our children, right? Because so many things can scar them and lead to lifelong problems when they grow up. So the psychodynamic influence is felt to be that it was a result of very early disturbance in the mother-infant interactions, and this developed delay in the ego development and an unfulfilled sense of separation of individualism. Because of this behavior associated with food and eating, it served to provide a feeling of control over one's life. So it's a control thing with these eating disorders, and that is where the treatment will be geared towards. So historically, parents have often been presumed to be over-controlling and perfectionists, which was thought to cause the child to develop these eating disorders. But of course, this theory's been very problematic because not all siblings develop eating disorders. And there's not enough evidence to support these claims because of that. But what they have found is both perfectionist and depressive tendencies do appear to be common in clients with anorexia nervosa. So they tend to be a perfectionist and tend to have depressive issues. So the American Academy for Eating Disorder came out with a firm stance on against any model of eating disorders in which the family influences are seen as the primary cause of eating disorders. And they condemn statements that blame families for their child's illness and recommend that families be included in the treatment. So that has been the change in what we used to think was a factor that the parents had a role in causing their children to have eating disorders. So when we look at nursing diagnosis, definitely imbalanced nutrition is a big one. Less than the body requirements related to refusing to eat, refusing to drink, self-induced vomiting, abuse of laxatives and diuretics. Also, deficit fluid volume can be risk for or an actual related to the decreased fluid intake, right? Because of also the self-induced vomiting and laxative and diuretic abuse causes major fluid volume deficits. Some other nursing diagnoses for anorexia and bulimia are ineffective denial related to the delay, ego development, and fear of losing the only aspect of life over which the client perceives some control, eating. So they can control. They don't feel like they have control, but they can control their eating. So that's one of the possible nursing diagnosis we could use. Also, disturbed body image. Like I said, they will look in the mirror, our anorexic patients, and see, a gross distortion of what their body actually looks like. They will see, they will feel like they're seeing someone who needs to lose more weight. Also, low self-esteem. And these are related to the retarded ego development. Goals for these patients are to achieve and maintain at least 80% of the expected body weight. Have vital signs, of course, blood pressure, lab, serum studies within normal limits is very important. And have them verbalize the importance of adequate nutrition. Some other goals are to verbalize knowledge regarding the consequences of fluid loss. So they need to be taught about, this is what happens when you do these acts, and of vomiting, laxative, and diuretic abuse, and the importance that they need fluids. They won't even want to drink fluids, especially any with any calories. So they struggle with dehydration issues for sure. And then also a good goal is to verbalize events that precipitate the anxiety, that bring the anxiety on. So if they can identify what makes them anxious and learn to cope with that and deal with that, hopefully that will improve their eating disorder. Also, another one, verbalize ways in which they can gain weight, gain more control of their environment and reduce feelings of powerlessness. For our binge eating disorders that lead to obesity, nursing diagnosis would be imbalanced nutrition, more than the body requirements related to compulsive eating. Sorry. Hang on just a sec. Okay. And so these folks will establish a healthy eating pattern for weight control and weight loss towards their goal, and that is progressing, and verbalize plans for future maintenance of weight control and relapse prevention. Interventions to restore nutritional balance, definitely. If emaciated and if they are skin and bones and they're refusing to eat, it may require that they have an NG tube for a while. If they are willing to eat, a dietitian will work with them to determine the right amount of calories that they need for adequate nutrition and determine a realistic weight gain. So also the treatment involves privileges and restrictions, and that it is based on compliance with the treatment and weight gain. We never, when we treat these folks, focus on food and eating, okay, because that causes them anxiety. What we do focus on is, okay, this is, you have to gain weight, and you have to comply with the treatment. If not, then you will lose privileges. Okay, so this is the part of the care that's given for these folks. Definitely we're wanting to restore nutritional balance. So they're going to be weighed daily. We're going to stay with the clients during meals, 30 minutes, and then an hour after. Okay, so 30 minutes allows them enough time to eat, but you don't want the meal to go on and on and on, because lengthy meal times put too much focus on the food and eating, and that provides attention and reinforcement. So we don't want to do that. We want to give them enough time to eat, but we don't want to have it drawn out any longer than 30 minutes. And of course, we're going to stay with them an hour afterwards to make sure that they don't induce vomiting. Okay, they don't do purging after they eat. So if weight loss occurs, then you have to enforce restrictions on them. But again, like I said, we don't talk about food, we talk about weight gain and following the treatment plan. And this is what you have to eat, to gain weight. And definitely it's important to establish a trusting relationship. Encourage them to explore their feelings and fears that contribute to the maladaptive eating behaviors, and acknowledge with them if their anger feelings of acknowledge that you understand they're angry about that loss of control over eating regimen. Okay, so it's very difficult for them to lose that control. But we're not going to argue with them. We're not going to bargain with them. If they're resistant to the treatment, just state matter-of-factly, what behaviors are unacceptable, how privileges will be restricted if you don't comply with the treatment plan, and help them develop a realistic perception of their body image and relationship with food. For our patients that are struggling with obesity, we want to encourage them to keep a food diary. That's very helpful in keeping track of what they're eating. Also allow them, definitely to discuss their feelings and emotions associated with eating. And with the client's input, of course, formulate an eating plan. Identify realistic weight goals or weight loss goals, and plan an individualized progressive exercise program also. So we need to teach them, about planning a reduced calorie, nutritious diet, how to read food labels, food content labels. Talked about the realistic weight loss plan, teaching them about that, and establish a planned program for physical activity again. Yes. With all of these, we want to teach the patient and family the nature of the illness, the symptoms of anorexia nervosa and bulimia, what constitutes obesity, causes of eating disorders, and the effects of the illness on the body, the negative effects on the body. I mean, people can die from anorexia nervosa and bulimia, because of the electrolyte abnormalities. So we need to make sure that they understand that. Management of the illness, principles of nutrition, ways that they can feel in control of their life. And the importance, of course, of expressing their fears and feelings rather than holding them in, and develop alternate coping strategies. Of course, if they're taking medications, we want to make sure that they're taking those correctly and letting them know about possible side effects, teaching them relaxation techniques to help with coping, and problem solving skills. Some of the support services for weight loss are Weight Watchers International, very good. Overeaters Anonymous, for anorexia and bulimia patients, the National Association of Anorexia Nervosa and Associated Disorders. And then there's also the National Eating Disorders Association. So we use for treatment, behavior modification. So again, issues of control are central to the cause of these disorders. And for the program to be successful, the client must perceive that he or she is in control. So we have to have them perceive that they have control over their treatment, or it's not going to work, because they definitely they have a strong need for control. So if we look at Madsky approach, this actively involves the family in the treatment. And parents need a lot of support because they can run into power struggles with their child. But there is reduced anxiety in the family when the patient accepts the parental demands for increased food intake and weight gain. They found that there was a 90% improvement in the patients with eating disorders when, the patient accepted that the family is going to control this for a while. So the first phase of treatment is designed to encourage parental control. So it's like, okay, I'm taking control of this for right now, and then you will earn back your control. So parental control of the eating and control is returned once the adolescent demonstrates the readiness and the ability to establish control in healthier ways. So that's the first phase. Phase 2 is control of maintaining weight gain is returned to the adolescent once the adolescent maintains 95% of their ideal weight. And then it's shifted to phase 3. Phase 3 focuses on assisting the adolescent to develop healthy self-identity. Okay, so they gradually give the adolescent control over their food intake, but they have to earn it. So successes have been found when the client is allowed to contract for privileges based on weight gain. Definitely, that always works. And has input into the care plan, how this is going to work. They need, with the control issue, they need to have some control over, and they should. And that they clearly see what the treatment choices are. So, with this treatment, they have control over eating. It's up to them. They have control over the exercise, whether to induce vomiting. The staff and the client agree to the goals, and it's a system of rewards that the client will choose whether to abide by the rules and gain weight, and then they will earn their desired privilege. Okay, so that's how all that works. Individual therapy can be helpful when the underlying cause is a psychological problem, that our psychological problems are contributing to this maladaptive behavior. There's no specific medications for eating disorders, but they're commonly, these folks have problems with anxiety and depression, so that is what's treated. So it's not treating the eating disorder, it's treating the anxiety and depression that they may have with this disorder, or that they frequently have with this disorder. So medications have been tried with some success. For anorexia, the SSRIs are really good. But again, they're not, no medications are specifically given for eating disorders, just to treat the associated symptoms of anxiety and depression. And that's with anorexia. Okay, so for with bulimia, they have found some success with using fluoxetine or Prozac, but they use a dosage triple of what the normal starting dose is. So they give 60 milligrams every day, and that was found to help with bulimia. And for binge eating disorders, there have been some success with topiramate or Topamax and lisdexamfetamine, a dopamine norepinephrine reuptake inhibitor, have found some success for eating disorders with obesity. So the binge eating disorders. Most studies reveal a combination, though, of medication and cognitive behavior therapy is beneficial, more beneficial than just medications alone. Okay, so that concludes eating disorders. All right. So I will give you, how about another break, and then we'll come back and we'll do neurocognitive disorders. Let me go back and start the recording. Okay, now we're good. Okay, neurocognitive disorders. So the first neurocognitive disorder we're going to look at is delirium. And it is a disturbance in the level of awareness, a change in cognition. The big thing to remember about delirium is it develops rapidly. And it can have a slower onset if the underlying cause is a systemic illness or a metabolic imbalance. But you see someone who is typically oriented, doesn't have any signs of disorientation or any cognitive disorder, and then all of a sudden, or over a few days, they develop, they get disoriented, they start having hallucinations and things like that. So the big thing to remember between the difference between delirium and dementia is this happens rapidly, where dementia is a gradual onset, okay? So it's very brief, usually a week, lasts a week, and rarely more than a month. And the big thing with delirium is once you find out what is causing the delirium and eliminate that, fix that problem. Symptoms will diminish in 3 to 7 days. But sometimes it may take up to 2 weeks for those symptoms to get better. But the big thing is this develops rapidly, okay? Symptoms, difficulty sustaining attention, shifting attention, distracted, disorganized thinking, rambling speech, pressured or incoherent speech. They can't reason well and, can't be goal directed. They're definitely disoriented to time and place. They've got impaired recent memory. They can have illusions and hallucinations, false thoughts of the environment, and then seeing and hearing things. So they can have also disturbances in their sleep-wake cycle. They can have fluctuations between being very agitated or in a complete stupor or semi-coma. And their emotional instability is characterized by fear, anxiety, depression, irritability, anger, can be euphoric or apathetic. They also have autonomic manifestations of tachycardia, sweating, face flush, dilated pupils, elevated blood pressure. So typically, if it is due to a general medical condition, it can be an infection. So we do see this in the elderly frequently, that they will be very lucid and become very disoriented and have all these other symptoms, perhaps, hallucinations, illusions, all of that, all these symptoms where they were fine before. So that's when we may suspect a urinary tract infection.
Yeah, the UTI. Yeah. Okay.
Did somebody want to say something?
No, that's what I was getting at. Like, usually you see like the increased confusion with the elderly related to the UTI, right?
Correct. Okay. Correct. So, if you have an elderly person who's normally very lucid, very, oriented, no cognitive issues, and then all of a sudden the next day, they're having all these signs of disorientation and, agitation and, delirious, so to speak.
Okay.
We suspect with them frequently an infection, and they are prone, our little ladies especially, to urinary tract infections that go unnoticed in the facility and until they get systemic, and they've got a systemic infection. It gets in their bloodstream, and then they start with the neurocognitive issues. So we always want to rule out an infection with these folks. It can occur after a high fever. It can occur with a metabolic disorder or hypoxia, lack of oxygen. Definitely, if we're not getting oxygen to our brains, it's going to cause us to have disorientation and other symptoms like this. Head trauma can cause delirium. Seizures can cause delirium. Migraine headaches can even cause delirium. Any brain issues like an abscess, stroke, electrolyte imbalance, and others, okay? It can also, we want to rule out any problems with intoxication, alcohol intoxication, drug intoxication, or it could be a withdrawal from a certain substance. Even like an anticholinergic or antihypertensive, steroids, corticosteroids, anticonvulsants, analgesics can all cause, withdrawal symptoms. Definitely alcohol. I mean, I could go on. Amphetamines, cannabis, cocaine, hallucinogens, inhalants. Okay, so any of these folks can come in with signs of delirium. And we also want to rule out toxins, solvents and fuels and lead and mercury, possibly poisoning, arsenic, carbon monoxide, and others. But with delirium, the big thing to remember is once we determine what has caused it and eliminate the cause, they will get better. So this is not permanent. So neurocognitive disorder symptoms include impairment in their abstract thinking, judgment, and impulse control. So they have problems in thinking, reasoning, memory, learning, and speaking. They lose their rules of social conduct, okay? They don't have that filter anymore. And they're not concerned with their personal appearance hygiene, okay? So that can be neglected. And also we can see some personality changes where they were just so mild-mannered. Now they're cussing like a sailor and being ugly and, being ugly to people. And so that can also be a symptom of neurocognitive disorder. And these disorders can range from mild to major, okay, depending on their symptoms. Mild neurocognitive disorder is also called mild cognitive impairment, and major is previously described by the DSM as dementia, but now we call it major neurocognitive disorder. Dementia is a general term we used to use. We used to use dementia. As I said, the DSM would say someone has dementia, and you will still hear people out in society say, "Oh, my mother has dementia." But dementia is just kind of a general term for a decline in mental ability, severe enough to interfere with daily life. But then we have different diseases, okay? Alzheimer's disease, as you all have heard about, is the most common cause of dementia, okay? But it is a specific disease. Dementia is a general term, so just remember that. Dementia describes a group of symptoms associated with decline in memory, reasoning, and other thinking skills. And there's a lot of different types of dementia, and many conditions can cause it. And we have to keep in mind that dementia is not a normal part of aging. It's caused, so not all older people are going to get dementia. And that's kind of a misconception. It is caused by the damage into brain cells that affect their ability to communicate, which can affect thinking, behavior, and feelings. But again, it's not a normal part of aging, okay, but it can occur. Just some special considerations for older adults, a little slide. So the one I like to point out is that sudden increase in confusion. What do you want to think? Urinary tract infection. Very common in long-term care facilities. So that's the first thing we're going to rule out. Also hypoxia. So we want to, check that O2 sat and see if that could possibly be causing it. And then definitely electrolyte imbalances can definitely cause increased confusion. So Alzheimer's disease is definitely a progressive disease. As the disease progresses, you will see aphasia, occur, which is inability to speak. They will get to the point they will not be able to speak. Apraxia is another term, and that is the inability to carry out motor function. Even though their motor function is intact, they are unable to carry out the motor function. They become irritable and moody with sudden outbursts over trivial issues. They become unable to care for their personal needs independently and tend to have wandering issues. So, sometimes that's what, the concern is with having to put an older relative into a long-term care facility is because of their safety. And there's other issues also, but the big one is that, they wander and they're afraid they're going to wander away from home. And then in the latter stages, also incontinence occurs. So when we look at Alzheimer's disease, there are stages. So the first stage, and again, Alzheimer's disease accounts for about 50 to 60% of all the cases of neurocognitive disorders. So it is pretty prevalent. It's the most prevalent. But it does happen in stages. The first stage, there is apparently no symptoms, but it's starting to progress. The second stage is the stage of forgetfulness. So they start to lose things, misplace things, forget names of people. Their short-term memory, they start to lose that. And they are aware, they're like, I'm losing it a little bit, and may feel ashamed and not let their family know. They try to keep organized. There was a great movie, and I haven't had time to look it up, about a young person who developed Alzheimer's disease, and it was because of that genetic factor. But we'll talk more about that in a minute. I will try to look that up and put that on Blackboard for you, because it's a real good movie. And that's what she had to start doing. She would start making lists and try to keep herself organized with lists and structure her routine to compensate. And often the family won't notice this. The person will notice it, and they'll kind of, be ashamed and try to hide it. So they'll start making lists to keep themselves organized. Then stage 3 is where the family starts noticing that they're having some issues. They start to have some interference with their work performance. They may get lost when they're driving. They're having problems concentrating and problems recalling names and words, finding the words and the names for things. Then stage 4, the mild to moderate stage, they forget major events. They forget, and this movie was so good, I've got to find that for you, because that's a real interesting way, because this sounds just like what happened with her. They'll forget that you've got a dinner date with your husband, so to speak. And they're, losing their ability to do tasks on their own, not understanding current news events. And they will try to deny that they have a problem at this point and confabulate to fill in the gaps of the memory. It's interesting that what the brain will do with this disease, where, okay, I don't know, but I'm going to, make something up. So they confabulate a story that's not true to fill in the gaps that they can't remember. Depression and social withdrawal are very common in this stage also. Stage 5.
That was stage 4. Okay. Thanks.
Yes. Yeah. Stage 5 is moderate decline. This is where they lose the ability to perform some of their ADLs independently. They become disoriented to place and time. They still know who they are, though. They're getting frustrated now. They're withdrawing and becoming self-absorbed. Then we progress to stage 6, which is moderate to severe. And again, unable to recall major life events or even their spouse. This is when it gets sad because they don't recognize family members. They're disoriented to their surroundings. They're unable to perform ADLs by themselves. They become incontinent at this point. They have problems with sundowning, and I've got a great slide on sundowning on the next slide, but this is where, when the sun goes down, they become more disoriented, more combative, and then they're having more problems with wandering. As I talked about, that can be a major issue that, at this point, the family, it's a safety factor where the family can no longer care for them. So if they have not been put in a facility before now, this is, the point they probably will be. They become very agitated and aggressive, which is hard also for the family to take care of, and obsessiveness. They have a real problem communicating also. And then the last most severe stage, the end stage, is stage 7, where there's severe cognitive decline, and they absolutely don't recognize any family members. At this point, they're bedfast and aphasic. They can't speak, and they're at the end. So complications are usually what kill these people or what they die from, but they become their muscles become rigid and contracted. Their immune system is becomes depressed. So, they're no longer able to be mobile. So with the depressed immune system and not being able to get out of bed, this, predisposes them to pneumonia. So a lot of these folks die of pneumonia. Urinary tract infections, sepsis, and pressure ulcers are common that can end up killing these folks. They, decreased appetite. They have problems eating, difficulty swallowing, and have problems with aspiration. So sometimes the pneumonia is caused because they've aspirated. And again, death is usually due to infections, sepsis, or aspiration. So with Alzheimer's, the onset is typically slow, and, you don't really notice in the beginning. It's not apparent to others, and it's progressive and very deteriorating. Sad disease. And here's our little picture of what happens. Sun goes down and the person becomes a werewolf, agitated and disoriented and more combative. So some thoughts on some causes that may be the cause for Alzheimer's is a decrease in one of the theories is, or the thoughts is, or the findings, I should say, is that it's a decreased production in acetylcholine that reduces the amount of the neurotransmitter that is released to the cells and result in a disruption of the cognitive processes. Other neurotransmitters also can be implicated in the disease and the symptoms are norepinephrine, serotonin, dopamine, and amino acid glutamate, and one theory is that the excess glutamate leads to overstimulation of the N-methyl D-aspartate, NMDA receptors, leading to increase in the intracellular calcium and subsequent neuronal degeneration and cell death. Okay, so those are a couple thoughts or causes. Also, they found a decreased level of somatostatin and corticotropin, also found in individuals with Alzheimer's disease. But what they do see, and this is seen on usually with the autopsy is when it's confirmed, where what they'll see in the brain are plaques and tangles. And these plaques that develop and tangles, if you can, kind of tangling up, destroy the neurons in the brain. So basically the brain is destroyed and just shrivels up if you've seen pictures. And this leads, of course, to the memory problems, personality changes, and eventual inability to carry out ADLs and other features of the disease. And yeah, it just basically kills all the neurons in the brain. It's very sad. Another cause can be head trauma. A head trauma can start this disease process. And the one I was talking about, the movie, which I'm going to look up and I'll post, write myself a note, is the one that, and I can't think of her name. She's a redhead. Anybody know the movie I'm talking about? But anyway, she had the family inherited Alzheimer's disease for sure. So there is a genetic factor there's a genetic factor in Alzheimer's disease, but there's clearly one that has a family pattern. And as many as 40% of Alzheimer's disease patients have a family history of the disease. But some studies indicate that the early onset, and that's what occurred with this one woman in True Story movie, is likely the familiar one, the family genetic factor one. So they're more likely than the late onset to be family related, family linked, genetically linked. And in this movie, all the kids got tested, and one of the children were showing that they were going to get the same, they were going to definitely get Alzheimer's disease. So it's very sad. And she was like a professor at a university, very smart lady. So it's really, really was sad. Okay, next assessment. Of course, we're going to look at the patient's history. When they come in, we're going to do, a thorough history and physical. So when did this start, frequency, how bad are the mood swings, what kind of personality changes, how long has this been going on, any emotional reactions, catastrophic emotional reactions that they've had, what kind of cognitive changes they've seen, any problems with, language, speaking, are they oriented to person, place, time, and situation? How are they are they appropriate in social settings, social behavior, and any current or past use of medication or drugs? Because, again, we've got to rule out that it's related to, and alcohol also, related to any medications they're taking, or street drugs or alcohol, or any possible exposure to toxins again. And then, of course, we're going to get a thorough history on their family history of any specific illnesses. And, has there been a family history of any neurocognitive disorders? Physical assessment, we're going to rule out diseases that can be causing the neurocognitive issues, any that can cause confusion, loss of memory, behavior changes. And then they're definitely going to have a neurological examination to assess their mental status, their alertness, muscle strength, all that, reflexes, sensory perception, language skills, and coordination. They're going to also go through some psychological tests to differentiate between neurocognitive disorders and what we find in the elderly, pseudo dementia. Okay. So the misconception is that all older people are going to get dementia, some sort of dementia. But it could be that they're depressed, because depression is also very common in elderly folks. I mean, look at all the changes and losses that occur in their life. And, it does, put them at risk for depression. So we do see a lot of depression in the elderly. But a lot of times they're misdiagnosed with dementia, where it's actually depression, because that's what practitioners go to first. So depression is the most common mental illness in the elderly, and often misdiagnosed and treated inadequately. So you have to keep in mind that symptoms of depression may mimic neurocognitive disorders. Again, because of the prevalence of neurocognitive disorders in the elderly, prescriber or healthcare providers kind of can sometimes too hastily make that diagnosis. I didn't get a chance to check this table page, but there is a table in the chapter that shows the comparison of symptoms. But definitely as nurses, we can help in the assessment by carefully observing and using the DSM-5. That, we diagnose people with major depressive disorder using the DSM-5 criteria. We need to use that also with our elderly folks, and not forget that, they have a lot of depression issues, and it's the most common mental illness in the elderly. So we don't want to just jump to, this is one of the dementias occurring. Also, we're going to do all the lab work to rule out that there's an medical issue, lab abnormality, infections, all those kinds of things that can be causing the problems with cognition. Other diagnostic tests, they may do an EEG, electroencephalogram, a CT to measure the size and shape of the brain. In the later stages, they can see that on a CT scan. And PET scan, MRI, or lumbar puncture to rule out an infection or hemorrhage in the brain. Nursing diagnosis, definitely risk for trauma, risk for injury, disturbed thought processes, impaired memory, disturbed sensory perception, risk for other directed violence, definitely, impaired, self and other, definitely impaired verbal communication towards the latter stages, self-care deficit towards the latter stages, situational low self-esteem, grieving for loss of their independence. So a lot of there's a lot of those that can be applicable to your patients. Goals, definitely keeping them safe. So have no physical injury, not harm themselves or others. Try to maintain reality orientation to the best of their ability. Discuss positive aspects about them and their life, and have them have them discuss positive aspects about themselves and their life, and then also participate in activities of daily living as long as they can, with some assistance. So protect the patient and others, real important. And again, maintain that orientation to the best of their ability, assist them with basic needs, pretty much hit on that, and assist and educate caregivers about what care they're going to need for their loved ones. Validation therapy. I really like this, this type of therapy. So some people can have the misconception that it's not harmful or not even cruel to try to insist that a person with mood, moderate to severe cognitive disorder, try to grasp what we know as the real world. But it's not helpful, and it is cruel to do that. But some people continue to do that. So I like this thought process, because there's no success in, trying to orient these folks. There becomes a time where, we cannot get them reoriented, and it just adds to their anxiety if we try to. So we need to accept where the patient is. In whatever the person with dementia claims as reality, no matter how untrue it is to us, it's important for us to accept that, and to communicate with the disoriented person by validating and respecting their feelings in whatever time and place is real to them, okay? Even though it's not the here and now reality. The theory suggests that validation principle is truthful to the person with neurocognitive disorders because they live on several levels of awareness, okay? For example, if an individual asked to see, and you will see this frequently in long-term care, if the individual asked to see his or her spouse that has been dead for many years, on some level with this theory or therapy, they feel like on some level that person does know the truth, but to keep reminding them that their spouse is dead only brings them back to that grieving process and distress, because it's like they're receiving that news brand new again. So it doesn't, it's not helpful to keep telling them that. So what this therapy advocates for is that we validate their feelings and the emotions that they have and integrate redirection techniques. And there's another box on this in your book, okay? So, it's better with these folks when they're, talking about, that their person's going to come pick them up. Talk about how they're feeling, that, you must really love your husband, those kinds of things. And yeah, redirect them. So I really like that thought process. Okay. Definitely patient teaching, family teaching about the illness, possible causes, what to expect, and the symptoms. Management of the illness, definitely work with the family with this, ways to ensure that they're safe, how to maintain reality orientation as long as possible. But again, there comes a point where it's more distressing for the disoriented person to try to orient them. That you'll need to provide assistance with activities of daily living, some nutritional information, any difficult behaviors and how to deal with those, medications, of course, administration, and any hygiene and toileting matters. And definitely connect them with support services. Respite care is important for these folks. Financial assistance if they need that, legal assistance, caregiver support groups, because it can be very, very draining. And, families, bless them, want to keep mom or dad at home as long as possible. Very, very much a commitment on their part and can be difficult. So they need a lot of support. medical treatment for delirium. So they don't really like to give medication to patients with delirium. We're trying to rule out lots of things. So we don't want to give them something until we figure out what's causing the delirium. Remember, this is an acute onset of confusion. So we need to find out what's causing that. There is a cause for it. And it may be medication related. So we don't want to add medication or continue medication that's maybe causing it. So typically they're going to wait to for a while to give medications. So the big thing is to determine what's causing it and correct the cause, the problem, or the underlying cause that's causing the delirium. Definitely staff needs to remain with these folks at all times to monitor their behavior. And these folks you want to reorient, okay, and assure them, okay? Not our severe Alzheimer's patients, but patients with delirium, yes. Star that. You need to reorient and assure them. You want the room to be low lighting, low stimulus, not low lighting, appropriate lighting, because if it's too low lighting, they may see shadows and that can, make them, have hallucinations or increase the hallucinations. So just adequate lighting, low stimuli. You don't want them in a noisy environment. Okay, talked about that. So if though, however, with delirium, they're having, they're so agitated and aggressive that they need a low dose antipsychotic medication. So they may be given an antipsychotic medication, and it may just be PRN if the patient's safety or the safety of others is in jeopardy, if they're so agitated and aggressive. But again, we try to hold off on giving medications until we figure out what's causing the delirium. Also, they will use benzodiazepines with alcohol or substance withdrawal to help with that. So for cognitive impairment, there's a few medications that we do use. One's not listed at the top, but it's donepezil or Aricept is common. Rivastigmine, Exelon, and Memantine or Namenda. Because donepezil, and rivastigin's actions rely on functioning cholinergic neurons, the effects of these meds may lessen as the disease progresses or advances. There's absolutely no evidence that these meds alter the course of the underlying degenerative process. There's no medication that's going to cure Alzheimer's disease. So we need to let the families know that. Yes, we're giving them medications, but it's to slow down the progression of the disease, but it cannot cure them. High levels of glutamate in the brains of Alzheimer's disease patients are thought to contribute to the symptoms and the decline in function. So memantine may protect these cells against excess glutamate by partially blocking the NMDA receptors, and has shown to improve cognitive function and ability to perform ADLs in patients with moderate to severe Alzheimer's disease. But again, underline, it does not stop or reverse the effects of the disease. It has shown to slow down the progression of the decline in cognition and function. For agitation, again, our antipsychotics may be used, and or if they're having hallucinations, we may have to use antipsychotics. If they're having big time thought disturbances and wandering, antipsychotics may be used. And these drugs cause fewer anticholinergics or anticholinergic and EPS than the older antipsychotics. So they carry a black box warning that all atypical antipsychotics are associated with an increase of death in the elderly patients with dementia. So we need to use them very carefully, sparingly. Okay. Okay. Haloperidol or Haldol, it's an old medication, but still commonly used, PRN typically, because of its proven efficacy. It's very effective. It does, however, have high potential for anticholinergic and EPS and sedative effects than the atypical that are listed on the other page. So it can lead to an increased risk of death in elderly patients with neurocognitive disorders. So used very cautiously. But if someone needs, is very agitated and we need to give them something, it may be used to calm them down. If depression is an issue, we're going to use the SSRIs, our first line of defense, right, for depression. And because of the fewer side effects, then we can use our tricyclic antidepressants. Again, we try to avoid those, but sometimes we need to go to those due to the anticholinergic and cardiac effects, especially in the elderly. They can be ordered trazodone, Deseril for insomnia. I see that a lot actually on the psych wards. They use this a lot. And any dopaminergic agents are helpful in the treatment of severe apathy. Okay. So the medications that we use for schizophrenia can be helpful if they've got apathy. They're just flat, blunt. Okay, lastly, we've got one question. Oops, I didn't advance the slide. So those are our atypical. Oopsie, what happened? Oh, here we go. Okay. A client has recently been diagnosed with mild to moderate neurocognitive disorder due to Alzheimer's disease. Which medication would the nurse expect the physician to order for the client's cognitive impairment?
C.
C, very good. Donepezil is used to improve cognition in clients diagnosed with mild to moderate dementia associated with Alzheimer's disease. Its action improves cholinergic function by inhibiting acetylcholinesterase. Okay. All right, we made it. You have time for lunch. All right. Let me get up here. Let's see if I have any questions. Oh, yes. Thank you. Still Alice is the name of the movie. Thank you so much. That is a great movie about the familial type of Alzheimer's disease that occurs in very young people. And I believe she was in her late 30s or early 40s. So thank you, Shaniqua, for looking that up for me. Let's see what else we got. New calendars posted. Thanks for today's session. Aw, thank you. Since we finished today, will we have a blueprint? Yes, you will. I am going to get my COVID vaccine, and then I will start looking at that at the test, and I will get that blueprint up as soon as possible. And I'll put it in an announcement, and I'll make sure it's connected to your emails. Any other questions? Okay, I know it's a lot of material, and but I think you'll find the blueprint to be helpful. And you can always email me if you have any questions, okay?
Thank you so much.
You're very welcome. Thank you for coming. I'm sorry not more of you could come. I'm sorry?
No, they just said thank you.
Oh, you're very welcome. Thank you, guys. All right.